So, shall we start?
We'll start? Yeah.
Okay.
Thanks. Good evening, everyone. This is Dr. Sayyeda Rukshida. I'm a psychiatrist. I'm based in Mumbai, and it's an honor and a privilege to be convener of the Indian Psychiatrist Society's Western Zonal Branch, a committee of women's psychological health. This is a special evening, especially for me and my entire team, because we've been trying to get together this workshop for quite some time. So it's in a way a dream come true. And all of us are really eagerly waiting to learn and upskill ourselves, especially those of us who work with women, because trauma is something that unfortunately most women face one time or the one way or the other in our lives, and especially trauma in our patients with psychiatric illnesses and psychiatric conditions. I think it behooves all of us, health professionals, but definitely all mental health professionals, to learn a little bit more about it. And like I said, it's an evening to upskill our skills and our clinical skills, but also a lot of knowledge. With this, it is a pleasure to invite a very dear friend and my chairperson of the committee, Dr. Khyati Mehtalia, for her welcoming address. Dr. Khyati, take it away.
Thank you so much, Rukshida. Very good evening to everyone. I, Dr. Khyati Mehtalia, chairperson of Women's Psychological Health Subcommittee of Western Zonal Branch of Indian Psychiatric Society, welcome you all for a wonderful session on trauma-informed care. Trauma-informed care is a practice that improves patient engagement, treatment, adherence, and better health outcomes. To speak on such a sensitive topic, we have with us none other than Dr. Prabha Chandra herself, Professor of NIMHANS. I welcome you, Madam. We also have another eminent speaker with immense experience in this field, and she is Dr. Shalini Anand, clinical psychologist. I welcome ma'am you too. We are also honored to have with us today the President of Indian Psychiatric Society, Dr. Anant Raju sir, and the President of SARC Psychiatric Federation, Dr. Gautam Saha sir. Welcome both of you. And our own President of Western Zonal Branch of Indian Psychiatric Society, Dr. Marwali sir, who had always been so much encouraging and supportive for this. Also, we have Dr. Dhananjay Ashturkar, our secretary, and all the senior psychiatrists and members who have joined online. I welcome all of you. Now, this is the second year of this committee, which has been started just last year, and we are happy to present various kinds of program. And along with us in liaison, we have the Hospital for Mental Health Digital Academy, which again has been gifted to the hospital by NIMHANS. So thanks to Prabha ma'am and thanks to Dipti, Dr. Dipti, who is in charge of the academy, for always welcoming the hand for us. I warmly welcome you all and feel honored to have such an elite crowd. It's going to be an insightful journey to learn about trauma and how to heal it. So once again, I welcome all of you, and I'm sure it is going to be a fantastic session. So over to Rukshida.
Thank you so much. A disclaimer: for some technical reason, we can't apparently get rid of the doorbell that keeps ringing, but that just tells us how many more enthusiastic people are joining in to learn today. So I beg everybody to just bear with us. It is an honor for me to now invite our President of Indian Psychiatric Society's West Zone Branch, Dr. Arun Marwale. Sir, please share some welcoming remarks and take the proceedings forward.
Thank you, Rukshida. Good evening, everybody. Respected Dr. Anant Raju sir, my friend and President of Indian Psychiatric Society, Dr. Gautam Dan, the President of SARC Association, Khyati Mehtalia, the Chairperson of this committee, Monali Deshpande, Vice Chairperson of this committee, and Rukshada, the convener of this committee, and all the members and all the delegates. First of all, I congratulate these committee members for starting with the very first and very important topic, because once in lifetime many of us definitely will encounter trauma and we'll go through certain steps. Some may overcome it, others may not. So many authors, they have suggested 10 steps how to deal with it, which will be discussed in this today's seminar. So I expect such event in future too. So again, I congratulate the team and say best luck to them, and take your permission. Thank you very much.
Thank you, sir. Thank you for your warm words and your always kind guidance to us. And it is now a pleasure for me to invite our chief guest of tonight, of today's CME, Dr. Anand Raju, sir. He's the president of Indian Psychiatry Society and always has a warm smile and a joke to share with us. And leading by example, I know we're talking about trauma, but this is something that all of us need in our life, more smiles. Dr. Raju, please share a few words.
Thank you. Thank you, Rukshada. I think in the outset, let me congratulate the sustained and also prolonged series of lectures and all being organized by the Women's Subcommittee, the Psychological Health Subcommittee of IPS West Zone, under the guidance and under the leadership of Dr. Arun Marwale. It is really happy that a moment of happiness that I am sharing the platform or podium or a screen or whatever name you give it with a lot of beautiful faces around, and happy to see Dr. PRABHA Chandra on screen after a long time, and happy that we are today talking about a topic which is not much publicized, which is not, I think, well orchestrated across the country in the psychiatric circles. Basically, the trauma-informed care, even though we know that at one time, trauma, child sexual abuse, those were hot topics to be discussed, but later on, somehow, I think it has gone. It has not been given as much importance as it deserved. We all assume, I think it seems that trauma-informed care assumes that all of us, I mean, invariably had history of trauma, even though we may not recognize that. So perhaps CMEs like this will help us in first recognizing, realizing about the trauma, then the recognizing it later on. Like, I think as we know that it is not like physical trauma that you have an immediate impact of the trauma, but you will have those impacts later on in the life. So recognizing that is not easy. And then responding to the trauma, like how best we respond to the trauma, how best, as Dr. Marwale sir was saying, some people, the response is good, some people's response may not be as good. And then finally, I think the trauma-informed care or trauma-informed therapy always directs us how best to resist that. I think we continue to have the traumas in future also. So how best we resist that. So probably these are the areas which today the learned speakers and knowledgeable speakers will give us, will enlighten us on these aspects. And I'm sure we would be highly, I think, motivated to listen to all these things. Because these are the areas where we need to concentrate on. By and large, in our clinical practice, most of the times we don't dwell into the past trauma, the events the individuals had gone through. So obviously, these are the areas most probably I think these speakers will touch upon, and I'm eager to listen to them. And I once again congratulate the group under Dr. Khyati, Dr. Monali, of Dr. Hina, and so many of you are, I think, all known faces to me, so, and good friends of mine. And except for that hidden trauma of bell and calling bell, rest of appears to be good. So I wish this program success, and I'm going to sit back and listen to you all. Wish good luck and all the best for a successful event today. Thank you. Thanks for
Thank you
inviting
so much,
me.
sir. Thank you so much, sir. And just an update, the doorbell seems to have gone away, so we'll be less traumatic from now.
Like the trauma itself always gets healed.
Thank you so much for being here with us and for encouraging us always. It is now a great pleasure of mine, and to welcome the next person, Dr. Gautam Saha. He's a friend, he's a co-traveler, he's a leader. He's taught us everything, he's encouraged us everything, all with ever smiling smile himself. Dr. Gautam Saha is the immediate past president of Indian Psychiatric Society, and he's also currently the president of SARC Psychiatric Federation, and nobody does a CME and or a conference like Gautam Saha. So I think his words of approval today would go a long way for all of us. Dr. Saha, if you could please share a few words.
Thank you, Dr. Rukseda. Rukseda, it's a really great privilege and an honor for me to be present here. It's a really, must thank and congratulate the committee. I mean, the Women's Psychological Health Subcommittee of West Zone, led by Dr. Kathy Metelia, Dr. Monali Deshpande, Dr. Ruksheda, Dr. Hina, Dr. Kalpona, and all, Dr. Sana, all of you have done wonderful job. Especially, I want to thank for choosing the topic, because it is not that it is a very common topic. It is something trauma-informed care that we are not very much acquainted with this type of topic, and there is another method of treatment. Whenever you do treatment, you should consider this, and this is the important. And we have two eminent speakers today, like Dr. PROF Chandra and Dr. Shalini Anant. You know that they are expert in this region, so I don't want to go into the subject, but it is so important. Already Dr. Raju and Dr. Arun Maral mentioned that trauma is a very important part of life, how to take it. I think definitely there is a relationship between the trauma and the resilience, and it ultimately it counts. And definitely we are eagerly waiting to listen to our eminent speaker. And thank you all, and especially the OSJN, the President Dr. Arun Marale, Secretary Dr. Dhananjay Astakur, and Vice President Dr. Umesh. All are my friends. And last year also, OSJN has done wonderful job. And this year also, they are the pioneer. They have started the academic activities. Congrats and kudos to you all. Thank you so much.
Thank you so much, sir. Thank you so much for being so kind and encouraging. With this, I am going to invite a dear friend, Dr. Hina Merchant, who's always very positive and chirpy and hardworking. She's the EC coordinator for a Women's Psychological Health Committee for the IPS West Zone branch. And Dr. Hina Merchant is going to introduce the topic in brief to us so that she can set the space for all of us to learn and grow and share today. Dr. Hina. You're on mute, Hina.
Thank you, Rukshida, for your kind words. I have been given this mammoth task of introducing this topic, which I'm sure our speakers will probably have a lot to tell us in the hour that will follow. So as we all know that when trauma occurs, it affects an individual's sense of self, their sense of other, and their beliefs about the world. Now, trauma-informed care is an approach in the human service field that assumes that an individual is more likely than not to have a history of trauma. Trauma-informed care, or TIC as it is known, recognizes and responds to the signs, symptoms, and the risks of trauma to better support the health needs of the individual who have experienced adverse childhood experiences and toxic stress. And to tell us that how we can utilize this trauma-informed care approach, we have with us today two eminent experienced speakers. So without much ado, I request Dr. Monali Deshpande to kindly introduce our two speakers, Dr. PROF Chandra Madam and Dr. Shalini Anant Madam.
Thank you.
I am honored and I feel privileged that I'm going to introduce the two most eminent speakers at the national level. We have with us Dr. Professor PRABHA Chandra. She is a professor of psychiatry and in charge of perinatal psychiatric services in NIMHANS. She studied medicine at Lady Hardinge Medical College, New Delhi, and her psychiatric training at NIMHANS. She has been there into maternal mental health services in India and has set up, she's the pioneer for a dedicated perinatal psychiatric service in public health, which includes mother-baby inpatient psychiatric unit. She is president-elect of the International Association of Women's Mental Health and has served as a temporary advisor to the WHO. Her main areas of interests are women's mental health, perinatal psychiatry, teaching methods, ethics, and palliative care. She has with her enormous publications in areas of women's mental health impact of partner violence, perinatal psychiatry, including editing several of the books. She has been an investigator in several research projects and is currently the PI of the Bangalore Child Health and Development Urban Cohort of Mother-Child Diets. We welcome you, ma'am. We also have today Shalini Anant, who has done her MPhil and PhD in clinical psychology from NIMHANS, Bangalore. She has been practicing counseling and psychotherapy since 1993 after her post-graduation from the University of Delhi. She has taught in Delhi University, Tata Institute of Social Sciences, Christ University, and Montfort College at various levels from UG to PhD. For the past 7 to 8 years, she has been learning and practicing trauma-informed therapy and has independently conducted training programs in the same for about 160 fellow therapists. She feels passionate about orienting mental health professionals to the trauma-informed lens in working with various physical and mental health concerns. So I welcome both the eminent speakers. The stage is all yours, ma'am.
Thank you very much, Rukshida, Monali, Khyati, Dr. Saha, Dr. Raju, Dr. Marwale, and Dr. Hina. Thanks so much for inviting us for this session. And in fact, I think there couldn't be a better time while we, to discuss trauma-informed care. With the war in Ukraine, with COVID just around the corner, there has been so much trauma in the world that this is a good time to talk about it, because we all know that it's not just our people who come to our clinic or who come through our hospital service door who have gone through trauma. Witnessing trauma again and again can lead to re-emergence of trauma, and we've seen that during COVID. A lot of people who had prior trauma actually had re-emergence of trauma and came back to us with great difficulty. So I think this is a very, very topical subject. The way we are going to structure today's program, and we discussed this with Rukshida, that we don't want it to be like a complete didactic, because it's all about skills, it's all about discussion. So what we're going to do is Shalini will do a little bit of a presentation to sort of set the stage, get some nomenclatures right, discuss what really we mean by certain particular definitions. And then we will have a couple of case discussions about what is, how people come to us, how people present to us, discuss a little bit about trauma-informed care. And then Shalini will talk about some therapeutic techniques which are used by trauma therapists. The idea also is that when a psychiatrist refers somebody for trauma related therapies, then what are they supposed to tell them? How do they explain trauma focused care to somebody who is being referred to psychological services? So I think these are many things that we need to learn. I also want to emphasize here that as psychiatrists, many of us may not be actually doing very intensive therapies, but we must all remember that when we talk about trauma-informed care, we're talking about care. And we must remember a few things here. and before I hand it over to Shalini, as a psychiatrist, as somebody who is involved in setting up services, to me, one of the most important things to remember is that trauma-informed care is strengths-based. So while we all know that, there are problems related to trauma in the form of difficulties, I think the approach is strength-based. The approach also is related to safety, because we know that people who go through trauma don't feel very safe in many spaces, don't feel safe in many relationships. And when I mean safe, I don't only mean physical safety, but emotional safety. So the idea of trauma-informed care is to also provide, safety in spaces. And the third S, so the first is strengths-based, the second is safety, and the third is that it's not enough for you as a psychiatrist alone to be trained in trauma-informed care. I think it's very important for the clerical staff, the person who takes the appointment, the receptionist, the security guard. Everybody needs to understand trauma-informed care. And that is why they say that trauma-informed care is about services. It's not just about a person. So I think this is something that we cannot forget, because a person who's gone through trauma, the first person that a patient meets is usually not you. You are probably at the end of the corridor. There are 3 or 4 people before you who the person will meet, and all of them need to ensure that it is, the care is trauma informed. So I think these are some things that I think are very important. So as we listen to this whole talk and have a discussion later, we must remember that trauma-informed care is about organizations as much as about the individual and about the professional. So actually, trauma-informed care should be there in judicial services. Trauma-informed care should be there in police services. It should be there in education. But I think in terms of mental health, it becomes even more important, because every individual who comes through our door is dealing with something related to trauma. So I think I just want to sort of emphasize that, we sometimes think of trauma-informed care as something very unique, something very special, but I think it's an approach to understand that people who come to us with trauma often bring quite a bit of baggage with them. And as we'll hear from Shalini, and we will recognize people whom we've seen in our in our clinic, that this reaction, which was ununderstandable, I was so nice to her and yet she was so angry. Some of these, or complete treatment adherence, when I thought definitely this person will come back to me for treatment. All of this can be understood in the umbrella of what happens related to trauma, and for us to be maybe more empathic people, probably not to label too many people as difficult patients, because these are the ones who probably experience the most trauma. So on this note, I'm going to hand it over to Shalini for the first level presentation, and then we'll take it from there. Shalini.
Thank you, Dr. Prabha, and thank you everyone for being enthusiastic about this topic. I feel very passionately about it, and I'm very happy that we all have what we call the beginner's mindset, which is known to be the best way to learn anything. So let's see, a lot of what we are going to talk about today, people may be knowing, but maybe some of the things might get a little tweaked, and I will try my best. So I will try to wind up very briefly what I'm going to say, and then maybe, as Dr. Prabha said, we'll take up other things in discussion. This is broadly the outline that I have. I'll just briefly talk about what is trauma-informed care, what is trauma, a few principles and beliefs that guide a trauma-informed mental health professional, what can a trauma-informed mental health professional do, and then we'll go on to case discussions. So as again, Dr. Prabha has just mentioned, that trauma-informed is a term which is used for individuals as well as organizations or programs. Any setting in which it is recognized that trauma is quite widespread and that there are potential paths for recovery also. So one is to recognize that it is highly prevalent, very, very important to recognize, but also that it is possible to treat the trauma. A trauma-informed setting would recognize the signs and symptoms of trauma in clients, families, staff also, and others involved in the system. It responds by fully integrating what knowledge we have about trauma into policies that we create, in the procedures that we follow, and the practices that we carry out. A trauma-informed system seeks to actively resist re-traumatization. That is a bare minimum that we can do. So whether we treat trauma or not, we must take care to not re-traumatize anybody. Why do we need to talk about trauma-informed care in psychiatry? The last batch of trauma therapy training that I conducted, which had all therapists and a couple of psychiatrists also, I think Dr. Janki is here with us, she was there with us. So I just gave them one homework to identify one patient that they have who has not had trauma, and to come back next week with their answers. And everybody said they couldn't think of one person who did not have trauma. But I did that after explaining what can trauma look like, what trauma means. So if we identify and understand clearly what trauma means, it would be difficult to identify even one patient who does not have trauma. We know about this concept of ACEs, adverse childhood experiences, which was a very vast study done with more than 17,000 people across the world, including India. In India, Professor Rajesh Sagar of AIIMS Delhi was the PI. And it was found that adverse experiences across the lifespan affect our physical health and mental health in diverse ways, because adverse experiences change the way our genes manifest. So they affect at the epigenetic level. And there have been many studies. Those of you who registered early enough may have seen this TED talk by Dr. Nan Burke, and she talks about the vast effects that ACEs have. This is just a summary of the effects that traumatic experiences can have. It can lead to 15 times more chances of people ending their lives by suicide, 2.5 times of smoking, 3 times serious job problems, 3 times depression, 3 times absenteeism, 3 times antidepressant medication use, 4 times IV drug use, 4 times STDs, and 4 times alcoholism. This more or less covers the entire gamut that we are talking about. So to quickly run through what is trauma and also what is not trauma. So, as we know that it's okay to joke about things. So within our own families also, or friends, we may say, anyone who's doing something, we may say you have an obsession, but we know that a technical definition of obsession is something very specific. Similarly, we were all joking about this doorbell being a trauma, but it is actually not at all trauma. So it's very important to understand what is trauma and what is not trauma. Otherwise, we lose the point. So all of us can think of these patients or these survivors as carrying trauma: war veterans, survivors of domestic violence, survivors of CSA, severe physical abuse, which may happen in childhood or later, survivors of rape, survivors of bullying, and other big T traumas. Big T is the obvious trauma, the one-time event trauma, which is the criterion A in DSM for diagnosing PTSD. But do we suspect trauma in these? If a patient says that they've grown up with a mother who had depression, is that traumatic or not? They grew up knowing that their father had an extramarital affair. They grew up with a mother who often left the house in anger and they didn't know whether the mother's coming back or not. They grew up with an alcoholic father. They grew up finding constant disapproval in parents' eyes, no matter what they did. They grew up being told that their parents cried at the time of their birth as a girl because she was a girl. They grew up knowing and expecting to understand, be responsible and independent because they had 2 younger siblings and 1 sibling with polio. We are going to talk about one of these cases. And someone who tells you that they remember crying themselves to sleep on most nights. Would we suspect trauma in any of these? Or in someone who says that they were sent to their aunt's family in the city at 3 years of age and they hardly saw their parents after that. Somebody who was blamed by their friends and family for not being strong enough and not being bold enough, and they did not resist fondling by older boys. A 21-year-old telling you that they were never respected and accepted by the family because they liked to wear girls' clothes despite being born with male's genitals. Do we suspect these as trauma? So we have a concept called small t trauma, traumas which are not as obvious as one-time life-threatening events. We very often neglect them as traumatic, but they can be very, very traumatic. So trauma is defined as an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful. Emotionally harmful, very important to remember. Or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So it's a vast definition, something which is life-changing for a person, maybe in one go or slowly it has affected someone's life. So the next sentence is the definition which I like the most, because very often otherwise we get confused in the content. If the father left, is it traumatic? Or if the mother left, is that more traumatic? And so if we get confused in the content, we usually won't reach anywhere. So the definition that I like more is that if our neurobiology does not have the ability to cope with that threat, it becomes trauma for us. And this is a definition given by two psychiatrists in different ways, Bessel van der Kolk, who is the famous author of the book, The Body Keeps the Score, and Daniel Siegel, who's also one of the pioneers in trauma therapy field. So this definition is very interesting to me because everyone may have different levels of resilience. And if someone doesn't have resilience, it is again not their fault. They are not weak. Resilience also develops through healthy attachment bonds. If that is not there, that will obviously make the person more vulnerable. So these experiences may occur at any age or any time in the person's life. Trauma is also understood as not an event. It's not something that happened to us, but it is what happened to the person as a result of that event. So it is the internal effect that happened to the person which is traumatic rather than the event itself. Now, I have a question which you can think, and maybe we can talk about it later. Is that a good thing or a bad thing? That an event is not trauma. The effect of that event is trauma. So we can discuss when we come to the discussion. One of the concepts with which very often trauma is confused is stress. Very often in conferences, etc., I see stress and trauma have been clubbed in one section. But it's very important to understand that they are different. Stress can be caused by unpleasant experiences, whereas trauma is caused by horrendous experiences. There's a difference. Stress is day-to-day life experiences that challenge our coping mechanisms. And eventually we can cope and even develop resilience. So I usually equate stress with, when we go to the gym and we work out a muscle, we have a little pain, but it actually makes our muscles stronger. So stress is a little bit like that, and some stress is actually good for us. Trauma, on the other hand, is because of unordinary, even if it is common, threatening or overwhelming experiences about which the organism does not have enough ability or resources to cope, which results in a state of terror, helplessness, or lack of meaning. So the meaning making that we talk about, that is lost. Is this world a safe place or not? So we are all much more familiar with CBT, and we talk about core beliefs in CBT. So in CBT, we talk about beliefs about oneself, about the world, and about future. All those beliefs develop through early childhood experiences. And if there has been early childhood trauma, that will always lead to unhealthy or maladaptive cognitions. So stress is not always harmful, but trauma nearly always is harmful. All trauma is stressful, but stress is not always traumatic. Trauma can also be called toxic stress. So that can be one term which can be used. Toxic stress is trauma. There are different categories which we sometimes talk about when we are talking about types of trauma. Big T, small t, I just described. Ongoing past, as the name suggests. Intergenerational trauma is, again, when we see all our clients, when they have gone through some unhealthy experiences in their childhood by their parents. If you take the parents' childhood history, that would be almost always much worse. So intergenerational trauma is much more of a norm than exception. Developmental trauma is any traumatic experience that someone goes through in childhood, and shock trauma is any one-time event which can happen at any time. Shock trauma is shock trauma, and strain trauma is anything which is prolonged and maybe small kindling that is happening and which leads to an accumulated effect. Collective trauma is anything that a group of people goes through in our country sometimes. Religion-based riots, or women always go through collective trauma, or right now the whole universe has been going through COVID-related trauma of some form or the other. I wouldn't say COVID was trauma for everyone. I would say for me, it was stressful, except maybe for a loved one that I lost. But for people who went through very difficult circumstances due to COVID, it was collective trauma for them. Trauma can also be intrusive or versus negligent. All abuse comes under intrusive trauma, and all neglect comes under negligent trauma. Again, I must say, abuse is very often recognized and identified as trauma, and neglect, most of us do not identify as trauma, whereas there are studies which say that neglect has even more of an effect than abuse in terms of changing the neurobiology. Then we differentiate between primary versus secondary trauma. Primary trauma is anything that someone goes through directly. Secondary trauma is what, if we are listening to many people's trauma, we may go through. It's also called compassion fatigue. So these are many types. There will be many more, but broadly, there are three types of trauma: acute, chronic, and complex. Acute, I won't explain. Everyone knows that. Chronic, again, everyone knows. Complex trauma is exposure to varied and multiple traumatic events, often of an invasive interpersonal nature. So there you would see that there's like an overlap between chronic and complex trauma, but complex trauma is almost always of interpersonal nature and very often invisibilized, which makes it even more traumatic. That is insult over injury, because most people would invalidate and invisibilize that, saying that, what is the big deal? This is life. It's not trauma for you. Complex trauma is experience of multiple and or chronic or prolonged or ongoing developmentally adverse traumatic events. So all attachment trauma is complex trauma. And it can be sexual or physical abuse, war, community violence that someone witnesses as a child especially. There is always early life onset, and these exposures often occur within the child's caregiving system, including physical, emotional, and educational neglect, and child maltreatment beginning in early childhood. And the problem is that these experiences are difficult to escape from. The helplessness that sets in very early in the nervous system of the child stays, and very often, as we know, learned helplessness theory of depression. And if we try to ask people, when was the first time you felt helpless, we might get a lot of important information. So the reason why complex trauma is much more harmful than any single incident trauma is that single incident trauma has more community validation and universalization, especially if it is faced by many people. Whereas complex trauma often occurs in secrecy. Even parents may say, don't tell anyone, or you're not supposed to talk about family things to outsiders. So that is why it is much more longer lasting. They won't tell anyone, so it continues. There's also shame that if I'm not supposed to tell someone, that means there's something wrong. And maybe I'm the only one who's going through it, so it must be my fault. So they have a lot of guilt and self-doubt and even shame. Single incident trauma has a clear beginning and a clear end, but complex trauma seems endless. So it leads to a feeling of, again, helplessness. There's a poor sense of self and identity. Who am I? Because if the complex trauma started very early in life, then the sense of self, independent of trauma, has never been able to develop. Single incident trauma often has the possibility of reaching safe places or people after it's over, But because complex trauma is often perpetrated by supposedly safe people in power and in safe places, supposedly, the concept of safety gets distorted. So people would continue to feel unsafe in most places. And this leads to confusion, loneliness, long-term trust issues, helplessness, and self-blame. One of the types of trauma that I want to just focus on is attachment trauma. Attachment trauma is when a person feels frightened by the parent's behavior. And we say if the parent is frightening or frightened. A frightened parent is also very frightening to a child because of the mirror neurons, and also because the child doesn't have a very clear cognitive ability to discern why someone is feeling frightened. They take it upon themselves that maybe the parent is not happy with me being here and it's all my fault, and they take it as a normal way of being. Being frightened becomes the normal way of being. Caring for parents, as we know about the concept of parentified child, is once in a way doing something for the parent when you are very young is okay. But if it's more of a norm that you are supposed to take care of the parents, especially emotional needs, we know as parents how difficult and challenging, even though it is very satisfying, it is a difficult job to be a parent even as an adult. And when a child is given that role, they can never ever do it well enough. And then the belief sets in, I am not good enough because I have not been good enough in taking care of my parents. So parentification is always traumatizing. If one parent is frightening, abusive, or neglectful, and if the other parent is not protecting them from that, usually we find that the clients have much more anger against the other parent who did not protect them. There's a lot of betrayal trauma from that parent. When the parent is not able to soothe the child at times of child's emotional upset, and if once in a way it's okay, but if that's more of a norm, then it is very difficult. One thing I want to add before we move on to the next thing is that all of us may make these mistakes while parenting, but when there is a lack of any attempts to repair and lack of genuine and consistent attempts to repair, that is when it becomes trauma. It's not like if once the parent is looking frightened or frightening, the child will become traumatized and that's the end of it. So we talk about three different insecure attachment styles: preoccupied, avoidant, and disorganized. There are different names for these three. And all these three will always invariably indicate early childhood trauma. This is ACEs. ACEs is a very helpful scale developed by Felitti and Anda, basically Kaiser Permanente and CDC. It asks only 10 questions. 3 questions are about abuse, physical, emotional, and sexual abuse. 2 questions are about neglect, physical and emotional neglect. And 5 questions are about household dysfunction. Was there anyone in your house with mental illness? Was your mother treated violently? Was there divorce or separation? Was any parent ever sent to jail? Or was there any substance abuse in the family? So just with these 10 questions, we can get a lot of information. It takes hardly 2-3 minutes, but I don't like to administer the scale as soon as someone comes because we need to do it sensitively and when it seems okay to do it. But this just very brief scale itself can give us a lot of information about trauma. Quickly coming to a few principles and beliefs guiding a trauma-informed mental health professional. So these are the principles of trauma-informed care given by Substance Abuse and Mental Health Services Administration, SAMH.
Shalini, I'm just going to interrupt you here. There are a few questions which have come in based for the what you've covered so far. So can we take them and then move on, you think?
Sure.
Is that okay?
Sure.
Because I just feel that while it's sort of fresh. So one question is about, a lot of health workers during COVID felt losing patients was traumatic. Do we consider that as a trauma? You answered some of it, like how COVID was stressful for some, traumatic for the others. But would you sort of highlight a little bit of that, about at what would you call COVID-related trauma really?
Yeah, so it's very difficult to define it as such, but I think this example Deepti Bhatt has given, that would be traumatic because, when you're caring for patients and losing one person is so difficult for us, and when we are losing patient after patient, it can be we don't get time to recuperate. So like Gabor Mate says that trauma and grief are two opposite things. Why? Because if we are grieving, we allow ourselves time to grieve, then we will not get traumatized, meaning that it will not leave a long lasting impact. But if we lose one patient and then we have to start caring for another, and then we don't know how many patients we are losing every day or every week, then of course it can be traumatic, and hopefully we can take some break after that.
Thanks, Shalini, for that response. The other question is by Dr. Rana J, which is an interesting question. That trauma is of course not the victim's fault, and how, taking that into account, how do we stop intergenerational trauma or help the person live with healthy attachments as a child? Because I think the whole field of intergenerational trauma now is so important. And you mentioned the role of epigenetic changes and how what your mother's gone through, what your grandmother's gone through. In fact, there's a very nice article about why your grandmother's health is important for you, and what she's exposed to, why is it important for you? So we know that there is a lot of trauma of racism, trauma of colonization, trauma of war, trauma of intersectionality. There are many kinds of trauma which is passed around generations. So will you be able to discuss maybe in the next session a little bit about how do you help people handle intergenerational trauma? We know that sometimes parents talking too much about what they went through, like we've seen in Holocaust survivors, and all the time talking about the sort of negative stuff also impacted children. And Esther Perel in her talks talks about how her parents, who were Holocaust survivors, really gave everything a very positive spin. So it was she had more resilience about that kind of trauma. So I think some of that. Also, a very related question: how do we know the trajectory if a person is exposed to trauma? Why is it that some people are resilient and other people develop personality vulnerabilities? Maybe you can take the second one before we move on to trauma-informed care. Yeah.
Maybe the second one, I'll talk about it before we move to this thing, huh? Okay. Anything else?
There's a question on CTQ which I can answer about where to get access to it. Yeah.
Okay, so these are, I want to just run through these principles. The first is safety. We need to ensure safety, and not just what we are providing, but the setting in which the person is receiving the services. From everywhere they are feeling safe. The process of receiving help needs to be filled with trustworthiness and transparency. People need to know what is happening with them, why we are doing what we are doing, and they need to be able to trust. They would be able to trust if we are being trustworthy. Peer support can be very helpful, because otherwise feeling lonely with one's experience is very often the case. So if people can meet others with their similar experiences, it can be sometimes helpful. Working collaboratively and mutually is helpful rather than just working on the people. Making people feel empowered and they have a voice and choice. I have found that when we believe people's experiences, that really helps, because most of the times when people come to me also after having gone to many people, they say that this is what my mother did to me. Until now, wherever I have gone, people say things like, after all, she's your mother, or after all, she's gone through worse, or something like that, indirectly invalidating or disbelieving their experience, or maybe being judgmental about them. So that really doesn't help. Having awareness of cultural, historical, and gender issues really helps, which is why we have people from many different countries, also Indians settled abroad, saying that they want an Indian therapist because maybe they believe that we have more awareness of cultural issues here. So this is a few things that I have tried to put together. I have tried to say, what are the core beliefs that tend to guide a trauma-informed mental health professional. So when we are conceptualizing a case, when we are trying to understand why the person has these symptoms, So a trauma-informed mental health professional would believe in the importance of early childhood experiences much more than later childhood experiences. The reason is neurobiology. So when a child is born, a lot of the cerebral development is yet to happen. So in the first 2-3 years of their life, a lot of neuronal networks are still being created. And as we know that while something is developing, if something damages that, so we know about the Chinese foot binding, when a little girl is very small, her foot is bound so that it remains small. After she's become an adult, even if we open it, it's not like it'll become its full size now, because so very often we may say things like, okay, it happened in the past, now it's not happening, so why are you bothered now? So that can again be invalidating, because neurobiology has been affected. Of course, there are ways to treat that, but first of all, we need to validate. Epigenetics is literally means beyond genetics. We all know what epigenetics means. I don't have to tell you, but that is the reason why early childhood experiences are more important. And as I was mentioning, attachment bonds develop early in childhood, and what happens in early childhood can impact attachment. And in fact, that partly answers the question why some people become more resilient, because if in early childhood they have felt mostly safe and secure, and they have received consistent responsive behavior from at least one parent, ideally from more than one parent, then they are likely to be much more resilient, and whatever happens afterwards becomes buffered because they have felt secure in early childhood. So we briefly saw ACEs, adverse childhood experiences. We also are reading studies that positive childhood experiences are also important, which again answers, why some people are resilient. So it's like a weighing balance, that if there are more than enough positive childhood experiences and a few adverse childhood experiences, there is much more resilience that is likely to happen. So it's not like someone should have 0 ACEs, but the positive childhood experiences should be much, much more than ACEs, and that makes us more resilient. So also, being trauma informed, we believe in the role of life experiences much more than genes, or at least not only the role of genes, but also the role of life experiences. Also, we need to be a little more informed about the structure of the brain, and trauma does not live in the higher levels of the brain. So Daniel Siegel, one of the prominent psychiatrists working in the field of trauma, has given this hand model to in a very easy way depict the triune brain model given by Paul MacLean. And he says that we have billions of neurons in the brain, and 4 lobes and 2 hemispheres and various things. But in a very simple way, we can look at the brain as comprising 3 different parts: the higher brain, or the thinking brain, or the human brain, and the middle brain, or the mammalian brain, or the limbic brain, and the lower brain, or the reptilian brain, or the sensing brain. So this higher brain is what humans are most blessed with. We have the biggest frontal lobe. But this is the part which is responsible for logical thinking and cognitions, and also emotional regulation. So emotions are in the limbic brain, but emotional regulation happens from the higher brain. But the trauma does not live here, because this part is still developing in early childhood. And so the trauma which has happened is usually in the much lower brains, which are much more developed early in childhood. And so when we are using any techniques, just changing the belief system will not help, because it's like this part was not the eyewitness of what happened. So neither this part will have enough memory or enough language to report what happened, nor just working with this part will heal the trauma. So a trauma-informed mental health professional is aware of the role of lower parts of the brain more than the cognitive brain. Coming to assessment, a trauma-informed mental health professional will be sure to not re-traumatize the patient. Sometimes for this reason, even history taking can be postponed, and over that we need to prioritize stabilization. So from Pierre Janet, who was here more than a century ago, and later authors like Judith Herman, everyone talks about 3 phases of trauma therapy. The first phase is stabilization, skill building, and resource building. The second phase is trauma processing, and the third phase is integration. So the first phase is extremely important, and sometimes we even postpone history taking in favor of stabilization. A trauma-informed therapist would, or a mental health professional would know the importance of body. And like Bessel van der Kolk says, body keeps the score and the mind hides the score. And what this means is, again, the lower parts of the brain, which are more corresponding to our senses, are more aware of what happened, but they don't have access to language or too much thinking. But the mind, we will, when we are thinking from our mind, we will always underplay what happened with us. So most of the patients would say, yeah, this happened, but it's not a big deal. People have had it worse, and why should I be affected? And I have had a lot of privileges, and why am I being too sensitive? So the mind will always underplay what happened. Memory is often affected due to trauma. Why I have written memory in double quotes is because there are at least 4 types of memory, 2 explicit and 2 implicit. Explicit memory has semantic and episodic. Semantic is the information and knowledge, and episodic memory is our autobiographical memory. And 2 types of implicit or unconscious memory, which is procedural and emotional memory. All types of memory are affected. So the person may report things in a fragmented way, which means their autobiographical memories is got distorted or fragmented. Or their emotional memory may be very strong. So they get a smell and they have a visceral reaction because they are reminded of the emotion they felt when maybe the abuser used to wear that same perfume. So the memory can get really affected due to trauma in different ways. Also, a trauma-informed mental health professional is aware of the very high prevalence of dissociation. So everyone may not have dissociative disorders, but dissociation it goes hand in hand with trauma, because if someone is going through experiences which their nervous system is not able to handle, patients will tell you that, I could almost see it happening to me. So you would see depersonalization, derealization, and in very severe cases, you would see even DID or fugue kind of things. But dissociation is very highly prevalent. Once we start believing that and we start looking at things as dissociation, we will be able to find. Dissociation also examples would be that, someone says that I know this is bad for me, but I just don't know why I do. So there's dissociation between the limbic brain and the higher brain. Dissociation can also be between mind and the body, because the body keeps the score, the mind hides the score. So dissociation is any kind of disconnect between one's different parts or one's present and past. So anything can be dissociation. We can do one whole discussion on dissociation. Coming to treatment, the core beliefs of a trauma-informed mental health professional about treatment would be, we would always give hope. But before giving hope, we have to believe in hope. We have to believe that trauma can be treated. And the reason is that epigenetics is what gets affected because of trauma. And epigenetics is what gets positively affected due to good treatment also. All therapy which is effective, no matter which form of therapy, is effective because it has had a positive impact on epigenetics. So we need to believe and we need to convey that things can get better. Re-traumatization must be prevented. So if I can talk about the types of treatments, exposure therapy is re-traumatizing, and it is not at all a trauma-informed therapy. And the reason that is given is that someone who's getting lots of flashbacks are anyway going through exposure on their own, so we don't need to put them through exposure again. Among behavior therapy techniques, systematic desensitization is respected as slightly more trauma-informed, but there are much more advanced forms of therapy, which are trauma therapies. Relationship with a mental health professional is something which we all can focus on. Why is it that some patients feel very safe with certain therapists, certain psychiatrists, and not with certain? So we hear of horror stories of people being shouted by people being told, you have wool in your head, and it just goes round and round, and for years you're talking about the same thing. People are very badly insulted by treating professionals, whether therapists or psychiatrists, whoever. So that may be our own frustration when we have not found a more effective way of treating trauma. We may be taking out our frustration on the patient, which is similar to how a frustrated parent with their unhealed trauma may transmit intergenerational trauma to their child by taking out their frustration. So we need to learn more effective ways to treat trauma rather than taking out our frustration on our patients. So the mental health professional's own self, whether we are working on ourselves, whether we are working on our own healing, whether we have felt hope that our own trauma can be healed, our own beliefs, our own ethics. I believe just the 10 ethics that WHO has given, if we can follow those, we are keeping our word. We are, whatever we have said, we are doing that. That can itself lead to gradual corrective experiences and lead to what we call earned secure attachment. So we learned about 3 insecure attachment styles, but there's also a concept of earned secure attachment, which really happens. People do start feeling slightly safer in their lives, and the being of the mental health professional is much more important than the doing. We need to believe that as trauma is healed, the symptoms will abate. So there are people who have been in therapy who say that, even when I try to think about that episode now, I am not feeling disturbed. I don't have to try and avoid thinking about it. Even if I try to think, I don't cry. I'm not losing sleep. Even if I used to get nightmares, I'm not getting nightmares because the trauma is healed now. Their symptoms have abated. Trauma-informed therapy is much, much more than just support and helping the client understand trauma. It treats the trauma, it takes away the pain that was there, and it really works. I'm not saying it can work, I'm saying it works. So in terms of treatment, we can just give this information. When we refer people for therapy, we don't have to say, go and get counseling or go and get CBT or go and get some support. It actually can treat trauma. What can we do as trauma-informed mental health professionals? We need to always take trauma history as regularly as we take developmental history, family history, medical history. But we must not rush into it, because taking detailed trauma history, asking questions right in the beginning can trigger and increase distress, and it can be re-traumatizing. It can increase flashbacks, or if the person has addiction, it can increase addiction. Instead of rushing into assessment, as soon as possible, we need to, of course, we will have to ask brief questions like what brings you here and all that, but we can also first come to what all helps you calm down, who all are your resources, who are your support systems, and maybe provide a few of these resources to the client. I have tried to put together a few questions of assessment that I have found helpful. You can choose whatever you find helpful. So we need to also take a history of positive childhood experiences. So things like, who did you feel the safest with as a child? Can you tell me more about that? Who believed in you when you were a child? Who believed in your truth, in your version of the story? Who helped you feel truly seen and heard? Who did you feel safe to talk to? Who kept your emotions in the center without reacting excessively or breaking down, making you become worried about them? So many patients tell us that, if I ever told my mother anything, she would start crying so much that I had to contain my own experiences and not bother her more than this. Who heard you without interrupting? Always take trauma history when the client presents with any of these: treatment-resistant depression, treatment-resistant bipolar disorders, treatment-resistant anything, I would say, chronic pain, any MUS, medically unexplained symptoms, substance abuse, eating disorders, turbulent relationships, emotional instability, any personality disorders. A few things that we need to keep in mind: observation is the most important tool, and we can observe the client's posture. Bessel van der Kolk says, start observing the patient as soon as they walk into your room, into your clinic, and not after they start telling you something. Observe their breath. Are they breathing well enough? Or does it seem like short and shallow breathing? What is their speech like? Facial expressions, eye contact, tearfulness at anything, Any efforts at evading any topics or minimizing things, we have to stop looking at that as a good thing. It's good that they are able to avoid topics. It's good that they are able to evade things. Also note any events or experiences that the client mentions repeatedly, that this happened. If they are saying it second time, third time, that shows that that has really stayed with them. Or anything that makes them teary-eyed or choked. Even when you're not taking trauma history, that means that that was traumatic for them. Very often while giving trauma history, they will give you only an official story. They will say whatever happened was for a good reason, or they were a good person, or they were themselves very disturbed. So the idea is not to find whom to blame. The idea is to understand the experience of the child and to heal the experience of the client when they were a child. How we ask matters much more than what we ask. So we need to use compassionate inquiry and respectful curiosity rather than just bombarding people with questions. So we can start with asking 10 best things that happened in your life, which make you smile, which make you proud and happy. Who did you have the most fun with as a child? What comes to your mind when you think of that? What do people who like you describe you as? What all do they like about you? What all do you like about yourself? What happened to you instead of what is wrong with you? Now, this is a very important change that we can have, but still we do not have to insist on that, especially right in the beginning. Can you also tell me 10 things that may sometimes make you sad or scared or angry, especially when you're sitting idle or trying to sleep? Or things which, when you hear about in others' lives or in media, make you slightly disturbed? Is there anything you wish had never happened? We all may have some things in our lives that we feel ashamed about. Is there anything like that for you? And you don't have to tell me what it is. So this is again, that freedom and choice we have to give to the person, that even if they are feeling ashamed about it, especially right in the beginning, they don't have to tell us anything. But we can just acknowledge that, yes, there are things which we all may feel ashamed about. Is there anything you wish or try to forget or not think about? And it's okay again if you wish to not tell me about it. If there were 3 things you could change about your childhood, what would they be? Do you remember any time you were physically hurt or unwell or sad? And then what did you do? What happened? As a child, when you got upset, whom did you go to? Can you give me an example? And then what happened? This question I have borrowed from Adult Attachment Interview. This is one of my most favorite questions. And that is one of my most favorite scales for assessment. Do you remember ever crying? Who consoled you then? Do you remember ever crying alone or trying to hide your tears? What do you remember about this? Was there anyone around about whom you felt confused, as if they were probably not being very honest? So many times we are seeing people who have had manipulative parents. So especially people with any cluster B personality disorders. So this question is very helpful with that. Can you tell me how it might have affected you in your life, whatever they have reported, in the obvious and the not so obvious ways? What are some of your memories which would bring a spontaneous smile on your face, which make you happy or proud? This I have already said, I think. Would you like to tell me about your first sexual experience? This can be a better question rather than asking about sexual abuse. Were you ever sexually abused or molested or harassed? If a client has guilt or confusion, which is very common about sexual abuse, we could ask, I hear you saying that you did not resist the abuse that you went through, and in fact, you enjoyed it. I'm just wondering if you would expect whatever age they were, that many year old child that you see around. So make it real for them that, do you know anyone else right now who's that age? And do you think they would be actually able to stand up for themselves and resist against an authority? This is a little bit like the CBT technique of counselor, friend, or decentering. And if not, would you blame them for the abuse that they went through? So this question is also supposed to bring in some amount of self-compassion, because most of our patients would be very low on self-compassion. Usually they are able to have more compassion to the others. So this is just an assessment question which can start your therapy process also. There are a few standardized measures which I don't have to read out the names of. I'm sure you know, or Dr. Prabha is also going to send for one of them. The first scale, Adult Attachment Interview, is just one thing that I would mention. It is not technically a trauma assessment scale. It's an adult attachment interview developed by Mary Main, but it is so beautiful I don't know if Dr. Hema is attending or not. She had attended I think the first batch of trauma training that I did, and she's become a fan of AAI, and she administers it with almost everyone. So among other things that a trauma informed yes, please.
Go ahead, Shalini.
Yeah. So as I have already mentioned briefly, we need to facilitate stabilization, always facilitate stabilization. And we can experientially teach emotional regulation. Sorry, it's not emotionally. Why I'm saying experientially is that, if we just tell people go and do breathing exercises or go and do meditation or whatever we believe in, it's again a very lonely experience. And one of the definitions again that Daniel Siegel has given is that trauma is something that happens to you when you were alone with it. So right now in the beginning, when we have not even started therapy, to tell someone to do something on their own as a homework is not considered a very trauma-informed approach. If we teach them right in front of us and do with them, so again, co-regulation is something which polyvagal theory, one of the trauma therapies, talks about. So when we do with them, that would be much more effective than just asking people to do it on their own. Prevent any re-traumatization, I can't emphasize it enough. Work collaboratively is very important. People should feel on par with us, not feel like we are working on them. Validate their experiences, and I would like to say a couple of sentences about this. Usually validation we do, yeah, I understand. But what we understand is something they don't understand, so like what Rogers had said, that, to feel what they are feeling and also to help them feel that we understand what they are feeling. So maybe in the case that we are discussing, I'll give maybe a couple of examples of how a detailed validation must be done. Enhance and focus on client strengths, and we are all dedicated towards finding a diagnosis, because we also may need to start some medication, but also focus on the client strengths. It's very important because something has kept them afloat so far, so we need to work on that. Help the client learn to come back within the window of tolerance. The window of tolerance, I haven't gone into the detail, but it's just a concept given by Daniel Siegel again, who says that when we are in the optimal zone of arousal or activation, we are able to be attentive, we are able to do what we are supposed to do. And if we are too aroused, we are hyper aroused, or the sympathetic nervous system is aroused. And so earlier we used to learn only sympathetic and parasympathetic. So sympathetic is what it is, but parasympathetic can be the optimal zone of arousal. But we can also be hypo aroused, in which the dorsal vagal activation may be happening, in which we are feeling down and out and shut down and zoned out, and maybe feeling very lethargic or even dissociated. So we need to learn ways to bring the person from hyper or hypoarousal into the optimal zone of arousal. Help the client gradually expand the window of tolerance. So initially, of course, we need to teach skills to come back within the window of tolerance, but slowly we also expand the window of tolerance so that the client does not all the time stay out of the window of tolerance. And with a little bit of stress, they can, but this happens over several sessions. We don't have to do it on a rush, otherwise we might be invalidating their experiences. Providing peer support can be really helpful. Refer for trauma-informed psychotherapy, because it's very, very important to remember that it is not a modality which only helps people feel slightly better. It is not just a supportive therapy or counseling. It is trauma-informed psychotherapy, which treats the trauma from the core, and people actually get better. People's symptoms go away. This I will not go into. I have more or less covered this, so I can pause for now.
Shalini, I think we'll take the case discussion, and then there are a few questions which we can handle.
Okay, is that fine?
Yeah.
All right. So I'm just presenting one case which I have written in the first person. Of course, the name is changed. I am Tara. I am 55 now. I live with my husband and mother. I began smoking as an adolescent, and I desperately want to quit, but I just can't. I want to work on my anger and on always feeling hassled. I was 15 when my father died. I could not go to college and had to start working after completing 12th. I got married at 22 and quit working to look after the 2 kids I had over the next 6 years. My son and daughter are now both adults living abroad. My husband has had a good job. He's about to retire now. He's a very relaxed person. He never makes a fuss about anything. I used to find him too lenient with the kids while I wanted to discipline them well. I feel very guilty to remember how harsh and impatient I was as a mother while bringing my kids up. I've also had frequent fights with my husband. I was exhausted as a young mother, and then we had to shift 22 houses over years because he had a transferable job. We have hardly had any intimacy for the last 7-8 years, mainly because I usually feel upset with him. I'm the oldest of 3 sisters. And when I was 2, my second sister was born and developed polio very early. I remember everyone saying she was so pretty and what a loss that she got polio. By the time I was 4, my youngest sister was born. My mother must have been very busy. I have really no memories at all of having her around until at least 7-8 years of age. Everything was about my sister. I was informed one day that I have to change my school and go to my sister's school to accompany her. My mom and everyone took delight in dressing my second sister up while I would be added in as an afterthought. I remember mostly being on the sides waiting. Somehow it felt like my fault that I was not pretty. When I have to go for any social functions now, I fret over it for weeks. I try different attires and I do not like myself in any of them. Despite repeated reassurance from my husband, I keep imagining that people would look at me and make comments, even though I know no one makes comments now. I was always a very curious child, but that was not liked by my family. My uncle would twist my ear if I touched his radio. He would whack me on my knuckles if I wanted to sort his mail by color. I loved playing outdoors with boys, but my mother would angrily shout and call me in if I crossed the curfew time. It was embarrassing to see all my playmates shocked at the anger she had in calling me. My father was a warm figure, a good cop. He was playful and loving, though he was busy. He was unwell for about 2 years and then he died when I was 15. After that, for about 4 or 5 years, it was really bad, especially the first 2 years. I remember once at a neighbor's house, I kept playing till late. And when they asked me if I did not want to go back home now, I told them home is not fun at all. This memory she told me many times, so I took it as a trauma memory and I processed this. Mom was obviously very sad and busy, and I became the son of the house, running all errands, but not even once my mother thanked or appreciated or even looked at me with love. I often felt invisible and knew there was some latent expectation that you should just understand. Sometime in childhood, I began sucking my thumb. I still do it at times secretly. I have had this perpetual frown on my forehead. I saw it even in my pic that was taken when I was 4 or 5 years old. I do not know how this developed and when this developed. I feel very guilty that I'm so short-tempered, always angry. Once my husband and I had an argument over a small matter, and then I left the room to make tea. He came from behind to cajole me, and I picked up the boiling hot water and splashed it onto his face. My feminist daughter reprimanded me, saying, if dad had done this to you, I would have reported him. I felt very ashamed and guilty about this. This was the wake-up call, and I decided to go for therapy. I often find myself trying to please people as if I believe I'm not good enough. I keep feeling guilty about smoking, yet I keep smoking. I love gardening and painting and cycling, but most of the times I keep making grand plans for these and just do not do these. I do not have panic attacks, but I'm often feeling on the edge. I do not want to feel like this. I have everything. My husband earns well. My children are doing well. I hardly have any responsibilities. Even after my father died, I was never starving. We were all okay. People have had it so much worse than me. This is the case. I was just wondering if people want to say what case conceptualizations we might have, what treatment goals and plans you might have. Do we see any trauma in her life? And are any of her current symptoms seeming like remnants of unhealed trauma?
Thanks, Shalini. I'm sure there are people who would like to respond to it. I mean, maybe we can just take does Sarah have any trauma? So there's somebody's written neglect trauma.
Yes.
Any other trauma do we think Sarah has? definitely neglect, because she reports that after the birth of her second sister, she was really not paid much attention, and mom basically focused on the sister. Feelings of inferiority. Okay, Sabha writes complex trauma. Shalini, you can take some of these things as discussion. Emotional abuse, rejection, some degree of parentalization.
Yeah. Emotional abuse of the mother was shouting. Abandonment fear. Yeah.
Yes, death of father seems to be a very big event for her, because he was like the person who was close to her.
Absolutely. And he was the kind of a secure base for her, but he also went away.
Okay.
But he was very busy. So whenever he was there, he was a nice, loving parent to have. So usually what we look at is between ages 5 and 12, the experiences that a child have are usually, because before 5, usually people don't have memories. And after 12, they enter adolescence. So 5 to 12 is the age. So she lost her father at 15. So, but whatever happened before that was already traumatic enough for her. She had already started sucking her thumb and she was having this constant frown. And by the way, now she doesn't have the frown. Many things are gone now.
So would people like to discuss a little bit about, what treatment goals could we have for her? And then we can hear from Shalini what Shalini did for her. What do we think we need to do? So her anger seems to be, her anger about the past seems to be projected onto the husband now. This lack of intimacy, the fact that she is not able to be intimate with her husband, could be one treatment goal. The anger could be another treatment goal.
Yeah.
But also maybe her feeling of inadequacy, the fact that she'll be judged. I'm not good enough.
Core belief, yes. And there was also intergenerational trauma, no? Because she took it out all out on her children.
On the children. So Shalini, would you like to give how do you handle this situation?
Yeah, so I use a number of trauma therapies. I'm trained in EMDR level 1 and 2, and I also use a lot of parts-based work. We have many therapy models of trauma therapy: internal family systems therapy, ego state therapy. We also have many body-based therapies like somatic psychotherapy, sensory motor psychotherapy. So through an integration of these methods, so my focus actually, I never worked on her anger and never worked on her intimacy, but both are better. So I treated her trauma, and her frown is gone. And there is, like, they're not very intimate. Her husband is, so she's much more warmer to him, and they both live much more intimately, and there are very few fights now. Of course, there are a couple of flare-ups which happen, which I would also think are kind of normal. And she's also apologized to her children. So I worked with self-compassion. I worked a lot with her, improving her self-compassion. And of course, I took specific traumatic memories and I did EMDR with them. I worked with her body and her posture. So when we say that, the trauma lives in the body, that's why working with the body becomes extremely important. So when we see anyone with a slouch, anyone who's dragging their feet, anyone with a frown, anyone with their shoulders hunched up, any of these, when we notice, if we start working with the body, out of all the different things, for me, initially working with the body was the most difficult. Somehow we are trained to work with the mind, and we always thought that is like a better approach or whatever, but working with the body has really helped. So yeah, I used an integration of different trauma therapy modalities.
Shalini, there are a few questions which have come up before this, and I'm just going to ask you. Some of them you've answered.
Yes, I did inner child work, yeah.
Yeah. One is about, some questions related to what you mentioned about positive childhood experiences. So would guiding the patient towards focusing on PCEs more than ACEs be a valid approach, or would it be considered invalidating the person's lived experience?
So I didn't put that down. One of the things I wanted to put down was some of the don'ts. So, some of the things which we should really try to avoid doing is talking about forgiveness, talking about, asking them to look at the brighter side of things, talking about resilience, talking about even PTG, post-traumatic growth, which is a very valid concept. It's a very important and very valid concept. And almost all our people who had undergone trauma, when they heal, they really show a lot of PTG. But, when we as mental health professionals start talking about, forgive someone or, look at the positive side, it's really very, very invalidating. And because there are enough number of people who have told them this, so they don't need to come to us to hear about this. But what happens is actually, so even this, so one of the memories I had taken was that she's saying to the neighbors, home is not fun at all. So when I have worked with that, she has been actually able to remember how many positive things were happening at home. I never asked her to look at that. But when that trauma, remember many positive things which were happening. So while this is the goal, but we don't go through that. We arrive at that in the end when the trauma is healed. And yes, somebody has mentioned inner child work, which is a very, very powerful technique, which is a parts-based work. So basically the adult part heals the inner child part through the therapist or through whoever is working with them. And that really helps because you provide to that inner child what that child is lacking, sometimes reassurance, sometimes some guidance, sometimes giving them options, and sometimes rescuing them. So use of guided imagery, guided imagery we are all familiar with. So guided imagery techniques can be used in a multiple number of creative ways. So inner child work also utilizes guided imagery a lot.
Thanks, Shalini. There's a question about, would you consider earned secure attachment and transference? Like, how is it different?
Earned secure attachment is when someone has not had secure attachment, and either through a relationship with the therapist or through sometimes, a very happy marriage or through whatever other healthy relationships, they are able to start feeling that I am safe and I matter. And so all the negative core beliefs which were there are healed. So they are able to feel much more safe. They are able to have more healthy interdependent relationships. Transference is very different. Transference is the patient is imposing upon you beliefs that they have had mostly about their parents.
There's a question on how is, about how crisis intervention and trauma, are they sort of trauma work, are they same or different? I guess people with trauma can come in crisis, and at that point, stabilization becomes much more important than doing any in-depth kind of trauma work. Is that right? And
yes. Yeah. And people with PTSD might benefit from crisis intervention. When we are working with complex PTSD, it's not something which has happened right now. It's not a crisis, so okay. It may not.
So another question which has come back, we said we'd address it, is about how come some people with similar trauma are resilient and some people develop personality vulnerability?
Yeah, I think I responded to that at a couple of points that, when there has been, so there's this Alan Schroff and Daniel Siegel, both who are working on interpersonal neurobiology. They borrow from pediatricians saying that the first 1000 days from the day of conception are the most crucial in physical health and emotional health of a child. So if in those, so after birth for 2 years, if the child has felt safe and they have, so see, it's not enough to say that we gave food and shelter and clothing, but if the child has actually felt safe, if the mother was happy, and who will know this better than Dr. Prabha, that, the mother's health is so important, physical and mental health. If the mother's happy and is able to be consistent and responsive to the baby, that would make the child have that secure attachment, and after that whatever happens will not have such a deep, it will affect, of course, depending upon what has happened, but it will not be so impactful. So even when we look at PTSD, so many people go to war, but a very small percentage of them develop PTSD. So so there are longitudinal studies, which have looked at their childhood history, and they have found early childhood trauma in those who develop PTSD later. So it's the same thing. Everyone does not develop PTSD.
So would you say that it is dependent on one, whether they have gone through early developmental trauma, which makes them more vulnerable?
Always.
And maybe protective factors like the ones you mentioned, which are more positive experiences,
Positive
which happen,
childhood experiences,
which probably buffer and mitigate and help in scaffolding in terms of the emotional trauma that is there.
And thirdly, that time when the trauma is happening, no matter when it is happening, that time if they feel validated, rather than somebody saying, no, don't take it too seriously and forget it. So somebody is there to validate, support, and soothe the child depending upon whatever age they are and what they need.
In fact, one of the things that determines how the mental health outcome of CSA is that what was the response to disclosure.
Yes.
That is one big thing which determines how it eventually pans out. There are a lot of questions on body work, Shalini. I know that you're not going to be able to focus. I mean, it probably requires another workshop or a course or something like that. But could you just give some idea about the kind of body work that is done?
Okay, so I'll give you very brief examples. So some of the things that we heard may be also disturbing to us. So maybe if you take any one of them, that when you heard this, imagine you're hearing it right now and scan your body. So as if there's a scanner going over your body from the head to the toes, beep, 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 and noticing any sensations, no matter how mild. So maybe you're noticing it here, maybe you're noticing it here. Most people notice it somewhere between the throat and the belly. So wherever you're noticing it, and then we process that sensation. So there are different ways of processing. So you can, maybe sometimes that intrapalmal contact is helpful. So you just keep your hands on that without making an effort to change it. I repeat, without making an effort to change it, if you keep noticing it compassionately, it really helps. It may take slightly longer, but it will actually help at a deep level. Then there are many different methods. So observing the person's posture also really helps, because sometimes most people, when they start coming in the beginning, they say, what body scan? I don't know what to do. I'm not noticing anything. So then when you observe that, maybe their jaw is going tighter, maybe their shoulders going up, maybe they're slouching, maybe their eyebrows are going up, whatever you're noticing, then you can process that. So we use, maybe one of the examples that I can give you is pendulation, which Peter Levine talks about, who is the founder of somatic experiencing therapy. And he says pendulation, like a pendulum going this way and that way. So he says, okay, so you're noticing something here. Now, first you again scan your body and notice any one place where you're sensing anything pleasant or calm or light. So suppose they said it's feeling heavy or it's feeling tight. So you'll say, notice anywhere where you're feeling light or loose or calm. So then you notice this and that. So you can imagine taking one breath to this and observing this and breathe out, taking the second breath to the calm sensation, notice it and breathe out. Or sometimes if it is a bodily movement that, when you notice this, what you feel, oh, I become like this. Okay, so do this. So you can do this and then you open it. So you again shrink and open, shrink and open, shrink and open. Then Pat Ogden, who is the founder of sensory motor psychotherapy, she says that, when we've had these experiences, various experiences, even if you're looking at some of the obvious things like physical abuse, the person was not able to push the abuser away. So when you're thinking of that, when you're in that moment, this will not happen if we are just doing it intellectually. But can you imagine yourself being there if it is not too threatening, and then you physically push right now? You push and push and push. So we do it experientially. We don't say, when you go home, you can, when you think of this, you do it. So asking people to do it only on their own does not help, but doing it experientially, really, when we keep doing it over and over again, and sometimes it works in layers, that today it's feeling lesser, again we do it, then it feels lesser. So it depends upon what we are observing and what technique seems helpful that time.
Shalini, I think, we have about 5 minutes to go before we stop. I think you've kind of responded to most questions. I just wanted to ask you, so as psychiatrists, obviously many of us may not be trained in exactly in trauma-focused therapy. What are the sort of key things that you think how should we approach when we recognize that somebody's gone through trauma? You very nicely told us how you should take a good trauma history. I think it's very important, and I'm sure many of us will watch this recording again for those very good questions that you asked, which, you start with questions which are more, sort of don't hit the trauma directly, but make the person reflect. Also, the fact that it's a strengths-based approach, so you also talk to the person about their own factors of resilience, so that they don't always think of themselves as victims. You also had a whole list of positive childhood experiences which were there. So yes, taking a very sensitive trauma history, not rushing in, making sure the person is stabilized before you take on more. Any other guidance for psychiatrists who may not want to do intensive therapy, but like you mentioned, somebody with bipolar may be having trauma, somebody who's gone through, who's treatment, like you said, treatment resistance. And this I found in my experience quite a lot. The moment I find that there are people with treatment resistance, in addition to comorbidity and treatment adherence and medication adherence, one of the things which one needs to think of is trauma. And there are studies to actually say, particularly in schizophrenia, the kind of hallucinations people are having are very often indicative of trauma. And particularly those who have treatment resistant hallucinations seem to have had trauma. So we will get a plethora of patients who will be, come to us with these conditions. As psychiatrists, what do you think our sort of, overall approach should be?
I think one can be validation. So I was saying I will give you examples of detailed validation. So suppose we take Tara's case. So if I do only one sentence validation, I understand it's been very difficult. But if I have to give her, say, even about her thing of, she used to spend months, I have to go for my husband's this thing, retirement function. Okay, for months she's thinking, okay, I'm wondering what to wear. Every day I wear something in front of the mirror. I spend hours, I don't know what to do. Okay, so I said, when you were a little baby, you were 2 years old when your younger sister was born, and she was born very pretty, and everyone started comparing. You don't choose. We don't choose our body. We don't choose what we look like. And we expect to find some affection in our parents' eyes, the joy that we wish to see in our parents' eyes. And I use a lot of Winnicott's concepts that the eyes which almost hold us and make us feel safe within them. And somehow you did not get that experience. And the delight, the joy that you every child deserves to get, you could not get. And there was never even a repair happening. Sometimes she says that she even overheard one aunt saying that if one child is less beautiful, if they had got polio, it was not such a big loss, and someone who's pretty got polio is such a big loss. So how is it surprising that it takes you so long to dress up? It's okay to understand, it's very easy to understand, and wouldn't we understand if somebody else was? So something like an elaboration. So if we connect, this is what I mean by asking for concepts. So if we are able to conceptualize that, their childhood experiences are, in this case, it was a one-to-one relation. Sometimes it's not even such a one-to-one. So if we can expand the validation, then she heard it for the first time from me. So nobody has validated that. So that validation takes like 2 minutes. So we can do that for sure. And we are all trained in various relaxation exercises. So maybe observing what we notice in their muscle tension and all that, and helping people relax, that can be helpful. And of course, referring people for therapy whenever we think that they can benefit from therapy. I know there's a dearth of therapists anyway, but if possible.
So I think important thing you mentioned was validation with specific examples, and particularly in the developmental trajectory. I think that's very important, rather than saying, you know, I can see that life has been difficult for you, or that you've gone through difficult experiences, but to actually hone into that specific thing and say, this particular thing as a child, you should have got this and you did not get it, and that must have been very difficult for you, kind of a thing, which probably really validates the main core. And I think another important thing that you mentioned is the sort of visceral reaction in trauma, which we often tend to negate because we are so much focused on the mind. And I have seen this happening with a lot of my patients. They say, you know, when I get angry, it's not from my brain. It actually comes from like somewhere within me. You know, it's somewhere deep within me. So the body remembers. You know, the body keeps the score, and body work probably is very important. So I often refer them for other kinds of somatic therapies where they can become a bit more aware of, you know, what is happening to them. And I think, like you mentioned, also, you know, trying to discuss about rupture without repair. I think that's so important. And even as psychiatrists, if there is a rupture, and that happens with a lot of patients of mine, when people who are very traumatized, sometimes if I say, for some reason, have not been able to keep an appointment, you know, there is severe abandonment issues which come up. Now you can leave it, you know, and then the person just goes through the same thing again, or you can create an environment where there's repair. So the person knows that if there is rupture, there will be repair, which is something they have not experienced. So I think these are some things that we all can do, being, you know, when there is treatment resistance, look out for trauma, take a very sensitive trauma history, stabilize the patient first before probing, specific validation, ensure that there's repair, even if there's a smallest rupture. You know, not so much reassuring or being very, you know, too nice or too good, but to kind of have a very healthy kind of repair. That yes, you know, you must have felt terrible when this happened, but this is the reason it happened. It's not because I did not want to see you, and could we come back again and see you? So that rupture with repair becomes a very important thing. And also, like you mentioned, and we've also been discussing, the organizational experience of trauma-informed care is very important. You know, we always talk about individuals as individuals, what we'll do for trauma-informed care. But I think when we all work in systems, it's important for each person in that touch point that the person comes in contact with to actually understand trauma-informed care, not just enough for the psychiatrist to understand trauma-informed care. So, so I think these are my takeaways today, Shalini. And I'm sure there are people who want to, you know, learn more and, you know, understand more for the clinical practice. And I'm sure, Rukshida, there will be a demand for more sessions, and we'll come back. Thank you so much, Shalini, for this wonderful, you know, discussion that we've had. And I thank the organizers for this opportunity, and I'm handing it over to them.
Thank you so much, Dr. Prabha and Dr. Shalini. That was indeed a very, very interesting topic. I now invite Dr. Sana Khilji. Sana, if there are any other questions that people may have put up that we overlooked, and I think there's a raised hand as well. So if you want to moderate quickly for a couple of minutes. I think Deepti's raised her hand. Deepti, would you want to speak, ask a couple?
Thank you, Dr. Prabha and Shalini ji, for a wonderful you know, session. But it seems so less. To me, it seems it needs at least a day to just understand the concept and to start, you know, working on this. So I think, Kathy, we should plan something a bit longer.
Yeah, definitely.
Ma'am, if I may, you know, when you mentioned both of your, I mean, this is maybe a comment, maybe a question, rupture without repair. So very often, like in sessions, especially during the first session, especially if I'm dealing with somebody younger, I do kind of like tell them that if there's anything that I say during our sessions, if it hurt you, or if you, if you didn't like what I said, please let me know, and things like that. So that kind of like also, I think it's important during our process, because we're assuming the trauma is only happening outside of our clinic, but during sessions, because of their pre-existing experiences, and they are so primed and kind of a condition to see rejection, perceived rejection, or real rejection, that might be something for us to kind of incorporate in our daily practices.
Shalini, do you want to respond to that? I completely agree. Yeah. In fact, very often, even on sort of, when you're in a teaching institution, very often you have these big rounds, and sometimes they are very threatening to people who've gone through trauma. And I always ask permission from patients if they are okay with so many people. If they are not, they should let us know. If there are things that they don't feel comfortable, it's perfectly fine. So I think giving them, taking permission is very, very important, when you interact with them, because we just sometimes, like Shalini mentioned, how the whole power thing, that we tend to, and this is much more with psychiatrists, little less with therapists. We tend to do that. We tend to take things for granted. So I think it's important to also, I always ask, how was your experience in the OPD registration, navigating your space to me? What was that like for you? And sometimes you'll hear some very revealing comments about how traumatizing that was, how many times they have come to the clinic and gone back because the whole process is so triggering. So I think these are some things that, as you get more and more trauma informed, you tend to become a bit more sensitive about some of these issues.
Yeah, I totally agree with what Dr. Prabha is saying. Also, sometimes, while apologizing, we might get defensive, or, that half-hearted apology. If I have upset you, then I'm sorry, So instead of that, we can say that, I said this or I did this, and which is quite insensitive of me, and it's not okay for me to have said this, and I'm very sorry about it, which is like an unconditional apology. So that would be much more of a repair work.
Sana, you've raised your hand. You don't need to. This is your session. I just overtook it. Please go ahead.
Actually, the host was not allowing me to unmute.
Okay. So sorry. Didn't know that.
No, I didn't have any questions. I just wanted to coordinate if anyone has any questions.
Yeah, I have a question.
Yes, go ahead.
Yeah. Shalini ma'am and Prabha ma'am both. See, just an example, like there is a boy coming, a 12th standard guy, and he has that trauma that my mother used to beat me a lot with stick, with this, that, etc. when I was not studying. And he has got a very bad impression about that, still lasting in his mind. So initially we listen to him, we empathize with him, we validate that, yes, you must have felt very bad and all those things. Then after all those processes, do we come to that process that maybe she also was under stress? Not initially, but at a later time, or we should never say that?
That is not the point. No, of course, she must have been under stress.
Yeah, but when repeatedly the boy says the same thing in all the sessions, and with validation, understanding, he's still not able to come out of that, then what should be our next step?
I know about therapy, so I would just send him for therapy, because there are very effective ways, in a few, if it is just one memory, it will take just very few sessions and it will be gone forever. Okay. But usually it's never one memory. So once we start working, lots of things come out, and nobody has to live with the trauma. This is a myth that if something has happened, it will always stay with us. It's a very big myth. We are in 2022. There are very advanced psychotherapy methods which make the trauma go away. It doesn't hurt at all after that.
Also, I think, it doesn't help the person just because the mother had a mental health issue. the fact that he was beaten is really not going to help that person in any way. It may help you understand the context in which it happened, but it doesn't help the person very much. So I guess the focus should be on more working with his trauma rather than trying to intellectualize it or making him, because however much you do, and we've seen this, however much we say, oh, it's because of this, and she had a problem, think of it in her perspective, they will say yes to you, but they'll come back again with the same thing.
Yeah.
So yeah.
And if I may add, there are two ways of saying this. One is that we can say that what happened with you is very bad, but so what, your mother was going through this stress. The opposite also can be said, that your mother went through very, very bad experiences, maybe worse than you, but still you did not deserve to go through this. So we are acknowledging that she, but saying that you went through this, but it's okay because she went through worse doesn't help. It's actually quite re-traumatizing.
Yeah.
So sometimes what I say is that, it's even if you can empathize why somebody did something, doesn't mean that that was okay for them to do. And I can empathize, but I can't condone it. So, when you give them these kind of like words, then they don't feel guilty that I can't forgive my mother or my father for doing these kind of things, because that guilt that's associated with trauma is also something that doesn't allow the healing process.
So I would like to also say
Go ahead.
I would like to also say the opposite, that, many times people will say, why am I still upset with my mother? Because she went through worse, and why should I still feel upset with it? So I usually give some example, like, if I'm walking on a pavement and one truck comes and hits me and I fracture a bone, I need to get my bone healed, and there will be different reasons. Maybe he had an epileptic attack, or he was shot dead by someone, so he obviously lost control, or he was drunk, or he wanted to kill me. So for whatever reason I got hit, right now the point is that I first need to heal my own fracture. So that is why we come to focusing on the client rather than on the reason why someone did that.
Thank you, Shalini. I think, Rukshida, we need to stop.
Yes, ma'am.
Because otherwise, this is a very interesting session, and all of us are remembering the people whom we've seen, what we said, did we say the right thing, how can we make it better. So Shalini also runs courses. So Shalini, maybe you can tell us about the course you run, so that if any of us want to get trained better, we can access your course.
Sure, I'll share it. So I run this course on trauma-focused therapy. I've done 4 batches, and the first batch I did for 12 hours, but the last batch I completed last month, which was for 30 hours. And hopefully I'll be announcing the next one soon enough. So mostly psychologists, but also few psychiatrists and psychiatric social workers have attended and are benefiting from that. I think Dr. Janki and Gayatri and Hema might be here who have attended the course.
Thank you so much for that information. Just to back that up, at Prafulta at Mumbai, we do run a training course on somatic psychotherapy that's open for psychiatrists and psychologists. And I know Dr. Parul Tunk is from Mumbai as well, and she's a trainer for EMRD. So, if anybody wants any more information, please feel to reach out to any of the organizing committees, and we'll try and get you all the information. We were going to do a quick recap with Kathy on the workshop. So Kathy, if you can quickly do that in a minute, because I think otherwise Prabha Chandra ma'am is never going to come back for West Zone conferences.
No, as such, ma'am, it was a wonderful session. Everything in detail, like what is trauma-informed system, that is very important, which we didn't know. And like what are the types of trauma? Shalini ma'am explained it very beautifully, and how do we handle that? Especially some of the things like what we ask is not as much important as how we ask. Also, rupture without repair is really traumatic. And the ways we talk with the patient, the sort of questions we ask, everything was very, very insightful. Thank you very much for the session. And we really would like to call both of you for further sessions for more informative, and still we would like to learn more from you.
Thank you,
guess
Dr.
It's less than a minute.
Thank you so much. I'm more just concerned for my skin here, nothing else really. Thank you so much, everyone. And it is my pleasure to now invite Dr. Dhananjay Asturkar for a vote of thanks.
Thank you, Rukshita. As already Hattie has said, it was a very wonderful session, very insightful brainstorming. I couldn't, and I canceled my OPD to attend this. Thank you very much. Secondly, I found that Dr. Prabha Chandra Madam has given us a time in the very difficult schedule. Thank you very much, ma'am. At personal and professional also. Dr. Shalini, ANANT, psychologist from NIMHANS, thank you very much. It was very wonderful to have you. Our chief guest, Dr. NN Raju, President IPS, guest of honor, Dr. Gautam Shah, immediate past president. They had given their time for gracing this occasion. Thank you very much. Our very own president of zone, Dr. Arun Marawale sir, he's always with us. And first, specifically, I had to mention the team, which is very, very, very active since last 2 years, that is Women's Psychological Health Subcommittee. Prabha ma'am, this committee has done wonderful work in these 2 years, and this is the climax of, I will say this workshop is the climax of all this. And especially to mention Dr. Kathy, Dr. Monali, Dr. Rukshita, Dr. Sana, EC coordinator, Dr. Hina, and thanks to Gujarat Digital Academy for giving us this platform. And thank you very much to all delegates. Their number were more than 100, which I had seen once. So thank you very much for attending. And as Rukshita had said, we'll share the recording to all. Thank you very much.
Thank you so much, sir. And thank you, Dr. Gautam Saha, for being with us right till the end. And we appreciate all the support. And if the session is at end right now, so people can feel free to be a little casual and say hi to everybody, and the recording will stop now.
So I'm stopping the recording.